Hi, everybody. Welcome to our MD Stewardship webinar. I'm Dr. Horn with infectious disease, and today we're going to be talking about Legionella pneumonia. Now, if you have any questions at all, feel free to interrupt me or go ahead and type in the chat and ask any questions you have. Legionella, I always start with saying what a good topic this is because this is something that, it's important to think about when you're treating people with pneumonia. Could it be Legionella? Could they have Legionnaire's disease? Some parts of the country, it's much more common than others, but it still can occur really anywhere. And, who to test, when to test is also very important. We can talk about that. And this is not to be meant, this is not meant to be totally comprehensive and not meant to cover every single thing about Legionnaire's disease, but it is kind of foundational. It's kind of the high points, kind of the what I think are the most important points to hit, and uh, the things to think about when you think about Legionnaire's disease, when you think about Legionella. You know, um, a little bit about it, and most importantly, what makes it different than the other pneumonias? What makes it kind of a different organism? The characteristics of the organism, how do patients present? How should you treat? How should you kind of think about testing? So we'll talk about, and I kind of like to hit the high points, like the things that I think are the most important parts about uh, um, what to think about, right? So community-acquired pneumonia. We'll start with talking about community-acquired pneumonia, and then we'll go into specifically Legionnaires. So as far as risk factors for community-acquired pneumonia, and Legionella really is a community-acquired pneumonia, meaning it starts out in the community and then they get admitted to the hospital usually, and usually they can be extremely sick, requiring ICU admission. So risk factors, so older age, cigarettes, so viruses. So community-acquired pneumonia in general, if someone has something like classically it's influenza, if they have influenza, then they get more susceptible to getting bacterial pneumonias. So classically, they'll get um, influenza, they'll get the flu, and then they may get the flu, and then they may feel like they're getting better. They'll say, I feel like I'm getting better, and then all of a sudden they get worse. And so um, all of a sudden, they're like, I was getting better, whether they were diagnosed with influenza, like actually had a positive test, or everyone around them had influenza, and then they felt bad too. They might say, oh, I was getting better, and then all of a sudden I got worse. And that all of a sudden getting worse might be attributed to a bacterial infection on top of it, whether it's strep pneumoniae or whether it's Staph aureus. And Staph aureus becomes much more common after uh, an an influenza or another uh, viral pneumonia. They may not have influenza, but they may have um, uh, RSV. They could have really any other upper respiratory viral infection, and then get a bacterial infection on top of it. Alcohol use is associated with community-acquired pneumonia and also Legionella. Inability to protect the airways. So if a person drinks a lot and then they pass out, they're not able to protect their airway. They may have the fluids in their mouth just kind of going down into their lung, and usually it settles in the right lower lobe because the um, way the anatomy is set up, if you're upright and it goes down, and you're getting your fluids from your mouth going down into your lungs, or if you're vomiting and the fluids going down into your lungs, it will usually go to the right or lower lobe if a person is upright. If a person is in a different position, it will go to different areas of the lung, so it doesn't necessarily need to be the right lower lobe. And acquired structural or immune deficiencies put people at risk as well. Pneumonia classification. So there's location, and this is location, in the lung. So there's lobar pneumonias, which it's essentially a large, uh, a lot of edema, large opacity in one lobe of the lung. And then there's bronchopneumonia, where it's around the bronchus, and atypical, which atypical pneumonias are essentially everything that's not strep pneumo. Everything that's not strep pneumo is essentially considered atypical. So it's not your typical pneumonia, because strep pneumo is the most common cause of bacterial pneumonia, and everything else is considered atypical. And then as far as the organism, let's see if I can get my spotlight. So as far as the organism is concerned, there's viral pneumonias, bacterial, or other things like fungal pneumonias, which occur usually in people that are immunosuppressed some way. And how did they acquire the infection? Is it a community-acquired pneumonia, a hospital-acquired pneumonia, a ventilator-associated pneumonia? Is it an aspiration? Aspiration could also occur anywhere as well. And the reason for that classification is because, as far as community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated, the reason they have this classification is because uh, their different organisms become more common in different scenarios. So community-acquired pneumonia has a certain set of bacteria that's common. Hospital-acquired pneumonia, you get things moving up in the list. You'll get Staph aureus, whereas community-acquired pneumonia, Staph aureus, not very common unless you have influenza beforehand. But also things like Pseudomonas and community-acquired pneumonia, you really don't get Pseudomonas as one of the common causes. But hospital-acquired pneumonia, you'll get things like Pseudomonas, you'll get things like Staph aureus. And because of this difference in bacteria, it changes what antibiotics that we're going to give, right? And so that's really, why change classification unless it's going to change what antibiotics you're going to give to treat, right? And when it comes to what antibiotics, now I'll just say that the antibiotics sometimes uh, are the same, but the reasons for giving those antibiotics are different. Okay, so let's say a person, comes into the hospital with a community-acquired pneumonia, and they're extremely sick, requiring ICU stay. You may want to give vancomycin plus piperacillin tazobactam, which is Zosyn, plus a fluoroquinolone. If it's a community-acquired pneumonia requiring the ICU, if they're critically ill. So in that case, vancomycin would be to cover strep and staph, and Zosyn in those cases is essentially to cover very broadly, um, including Pseudomonas, and levofloxacin is to cover if they're coming from a community acquired, if they're coming from the community, the levofloxacin is to cover Legionella, right? Now, if they're in the hospital and you're giving vancomycin and Zosyn and levofloxacin, if they have a hospital-acquired pneumonia, if they have a ventilator-associated pneumonia, you may give vancomycin, Zosyn, and levofloxacin, but the levofloxacin isn't to cover Legionella. The levofloxacin and the Zosyn together are to give two different antibiotics to cover for Pseudomonas. So if someone has hospital acquired or ventilator associated, you're not thinking Legionella, because those are generally community acquired, and we'll talk about why. So if you're looking for more information, the American Thoracic Society documents, they have diagnosis and treatment of adults with community acquired pneumonia. Now, this is also approved by Infectious Disease Society of America, which is the ID Society. And so Legionella, it's aerobic. It's aerobic gram-negative bacillus. So it's a gram-negative. There are lots of different types. 90% of Legionella pneumonia is caused by Legionella pneumophila, serogroup 1. So this is important, and we'll talk about why this becomes important with testing. So 1 out of every 10 people who get sick with Legionnaire's disease will die from their illness. So it's can be pretty severe, and with a high mortality rate. Those who get Legionnaire's disease during a stay in the healthcare facility, one of every four will die. Legionella bacteria is found naturally in freshwater environments like lakes and streams. So there's usually, well, with test questions, there's always a water connection. And when patients come in, if I'm concerned about Legionella, I'm asking the patient about water. So I'm asking for a water connection. So what is it they do for work? I've had patients that are plumbers come in with Legionella. So what do they do for work? What are they around? Some people come in and they say they've been at the lake, and some people they're around these cooling towers that they have water and a fan. So they use water like a or they have humidifiers. They use water to cool for cooling purposes. Hot tubs are known for having Legionella, decorative fountains and water figures. So in the past, and it's getting not as common, hospitals will have fountains in their lobby. They'll have water spraying, they'll have aquariums and these things. And then more and more, they're trying to get rid of that and not recommend doing that because it could have Legionella, it can have other things in the water, especially if people are coming in, they're immunosuppressed, and then they have water spraying and misting in the lobby. That is not a great idea. And I've had patients that I ask them their hobbies, and they are gardeners, and they have misters out in the summertime, and they have a lot of misters overhead, and it's spraying water, and it sounds like that's where they got it because it's misting it, it's putting it up into the air, and then they're breathing it in. And so this is, um, what we want to ask about, what you want to think about that might put people at risk. So things like this, with a large community outbreak of Legionnaire's disease potentially associated with a cooling tower in Napa, California. So, what are they exposed to? And there are some regions of the country that have much more Legionella than others. And the reason is because, does their water supply treat Legionella or not, right? Does it get rid of it? So some water systems use monochloramine. So monochloramine is a chemical that's used to clean the water, and it will kill Legionella. And some systems don't use it and don't use chemicals that would clean the Legionella out of the water. I think all systems probably have a little bit of Legionella in the water. If you drink it, you're probably fine. But if it's misting and you're inhaling it, which is kind of like taking a shower. So if you're taking a shower and it's misting into the air and you're breathing it in, most people do okay, but some people get very sick, especially people that are at risk or immunosuppressed. So, oop. So after it grows in the water system, water containing Legionella can spread by droplets, and then you breathe it in, and then it causes a pneumonia. So most healthy people exposed to Legionella do not get sick. People increase getting that are risk factors. And this was, it was identified in 1976 in I think the Waterford Hotel. There's a hotel in Philadelphia where it was identified, and they identified it in Legionnaires and military people, and these are their characteristics. So when you think about it, they were over 50, they were all smoking a lot, they all had COPD, um, and a number of them had, weakened immune systems and things. But old smokers, they had in that hotel, they had a convention, and they had I think um, humidifier, I can't remember, their air conditioning system used water, just as we discussed, and then a whole bunch of them got sick, and that's where it was first really described. And the symptoms are going to be like really any pneumonia, cough, shortness of breath, fever, may or may not have muscle aches, headaches, but it's also Legionnaire's disease is associated with some GI issues, which is not usually um, consistent with other pneumonias. You don't really think of nausea, diarrhea, confusion. And part of that is because people with Legionnaire's disease, it can cause hyponatremia, and it can also cause elevated liver enzymes, AST, ALT, to be elevated. And so if you see someone and you see that in the labs, you can think, oh, maybe this is Legionella because it's um, associated with other lab abnormalities. And as far as, we were talking earlier about different types of pneumonia, it's typically a lobar pneumonia. So here's uh, lobar pneumonias, think um, uh, large areas like this, and not kind of, other types of pneumonias might have a little bit of haziness all over. Not lobar pneumonias. Lobar pneumonias are going to be dense, and an all in one area. It could be multifocals, meaning it's in different lobes, but generally it's very dense and large consolidation in one lobe. Now, in those guidelines that I was referring to, one of the questions, it goes by questions and then answers them, right? So should Legionella and pneumococcal urine antigen be tested on on uh, on all patients? And it says not routinely, right? So it says not routinely because it's not really common. In some areas, the common question that I get asked is when should I test for Legionnaire's disease? When should I be testing for Legionella? And and in some hospitals they'll say, "Oh, we've never seen that before." Maybe, right? Maybe, but also if you're not testing for it, then you'll never see it, right? So if you're going to think about testing someone, it would be a severe community-acquired pneumonia, such as an ICU admission, and then antibiotic failure for community-acquired pneumonia. So the patient's failing on your antibiotics, and that's because beta-lactam antibiotics don't work for Legionella. That's one of the main points of this talk, is that a patient that's worsening on like ceftriaxone, and they have a very severe pneumonia, then think Legionella. Could this be Legionella? Um, we do see Legionella every so often, Legionnaire's disease. We do see it every so often. Sometimes we'll see it in travelers. So when we ask, where are you from? Have you traveled recently? They'll say, yes, I just got back from, and the person I saw had just gotten back from Texas. And they said, yes, I just got back from Texas. Another person said, I think we've actually had someone that returned from Europe. And that's because we don't see it around here too frequently. But really, it's all over. And if people are coming from another location where their water supply doesn't treat for it, it would be another thing to put on the list of things to think about. Now, immunocompromising condition, is there a link? Is there a known location that they don't treat the water so much, or is there a current outbreak? So not necessarily would you test everybody, because I don't test everybody, but if someone's worsening and I don't know why and they're not on medications to treat it, or if they have any of the features we discussed. And as far as diagnosis, so here's the environment. It has air conditioner, think water connection. And then, what are the risk factors? And really, I mean, a lot of the pneumonias we see are people that are over 50, that are smoking, that are alcoholics, so that's not something that you could use that I would really think of pointing out to be a reason, that would be one of my top reasons. But as far as testing and diagnosis, you can you are able to culture it, although that's not usually what's done. Usually what happens is a urine antigen test, which we will talk about in just a minute. Urine antigen test, you can get a PCR, and a PCR would be like on a bronchoscopy. So if they do on the BAL. So if they have a bronchoscopy that's done, um, then and I'm concerned, I may add Legionella PCR to the BAL. And blood, not usually. We're not usually identifying it in the blood. It's usually either a urine antigen test, which is really the best way, or a PCR of a bronchoscopy. So the urine antigen test is now widely used as the first line screening method. So it would be Legionella urine antigen, and it's fast, it's low cost, it's pretty simple, and it can detect it pretty well. Now, is it 100%? specificity, meaning if it's positive, that's what it is, right? Um, so it's well suited. Now, this can only be used to detect Legionella pneumophilus serogroup 1, which is 90% of the cases. So it's good, but it's not perfect, right? So I've definitely had cases where the urine antigen is negative and a bronchoscopy PCR is positive. And people wonder, well, how can that be? And that's because the urine antigen test only does serogroup 1 and it doesn't do other serogroups, but there are other serogroups that can make people sick. So if uh, the PCR from the BAL is positive, that's what they have. That I would uh, uh, test and I'd be very aggressive or sorry, I would treat and I'd be very aggressive with treating if their PCR in their lung is positive. So the urine antigen is very good, and I recommend it. But if it's negative and your suspicion is high, I would still recommend keeping antibiotics to cover for Legionella. Whether it's levofloxacin or azithromycin or both, we'll talk about that in just a second. But um, the treatment, current guidelines for community-acquired pneumonia recommend either a fluoroquinolone, so levofloxacin or moxifloxacin. And they have levofloxacin or moxifloxacin because those are considered respiratory fluoroquinolones. And that uh, describing something as a respiratory fluoroquinolone means it also covers some gram positives like strep and staph. So I generally don't use Cipro to treat for pneumonias. I would really only use levofloxacin if I'm going to use a fluoroquinolone for a pneumonia. Or a macrolide, preferably azithromycin as first-line therapy for Legionnaire's disease. And several studies, they show no difference in mortality between patients treated with fluoroquinolones and those treated with macrolides. So whether you use levofloxacin or azithromycin, either one works well. There's also no difference in clinical cure, length of stay, or complications. So, when you're deciding what to give for Legionnaire's disease, levofloxacin or azithromycin would be good. Now, the way we identified it, right? So whether it's a urine antigen test is positive, if you have a positive urine antigen test or you have a positive PCR, you don't have a susceptibility report, right? So if there's not going to be a susceptibility report, you have to essentially just use one or the other, levofloxacin or azithromycin, or both, right? And here are the studies, levofloxacin versus azithromycin for treating Legionella pneumonia. And it was essentially saying no significant difference in time to getting better. And um, it they didn't have a significant difference with mortality. And then this is another one, and it was looking at um, it did not differ for patients treated with fluoroquinolones versus macrolides. So you could use either one. Now, you could use either one. What about using both together? So the efficacy of combination therapy with macrolides plus quinolones. So if you can use a levofloxacin, you can use azithromycin. Well, what if you use levofloxacin plus azithromycin? And combination therapy has most often been suggested for use in patients with treatment failure or severe disease. And if I have someone in the ICU and they're really not doing well, this is what I do. I would use azithromycin with levofloxacin together because, as we discussed, Legionella can have a high mortality rate. And if a patient goes from the community straight to the ICU when they go inpatient for a really significant pneumonia, lobar pneumonia, um, I would be very aggressive with considering Legionella. And if it's positive, I would use two antibiotics together to cover it. Now, the duration of treatment. So, extended courses of therapy are reserved for immunocompromised patients, those with complications like empyema, extrapulmonary infection, and patients with severe pneumonia or chronic comorbidities. So, moderate to severe, it would be levofloxacin or azithromycin for 7 to 10 days. and immunocompromised host, 21 days of levofloxacin or 10 days of azithromycin. And, I uh, get worried for some of these patients that have large lobar pneumonias, and they can be extremely extensive. I've seen some take up like half the lung or more. And, I want to treat for kind of a long duration in those patients because it's so dense and so large that I want to make sure that I'm kind of concerned about the blood supply to the middle of the lung, and is it able to get all the antibiotics in there? And um, so I would have kind of a low threshold to treat for a long time if they've been like intubated in the ICU for a while, or they're just if you're really concerned about them. So that's everything we have today. It's the high points, the I think the kind of the bullet points when it comes to what to think about when you're seeing a patient with a really severe pneumonia, what to think about when you're considering Legionnaire's disease. Any questions at all? So more and more, I want to make these sessions uh, um, more kind of foundational bullet point style to because I think that's better for recall when you're thinking about it. What are the main points that I should think about? What differentiates this from other pneumonias? All right. Thank you everybody for coming. And as always, if you have any questions about specific patients, you can always contact us and we'll discuss your specific patients and see what we can help you with. All right. Have a good day, everybody.